Good evening, classmates, as well as Dr. Robinson. My name is Mark Alexis. I'm a third-year professional doctor of pharmacy candidate from Miami, Florida. And today I will be doing my presentation on clindamycin versus Bactrim in uncomplicated skin infections. First off, the trial was supported by the grants of the National Institution for Allergy and Infectious Diseases and the National Center of Research and Resources. Essentially, to begin, the objective was basically to find out the efficacy between clindamycin and Bactrim and to see if there was a difference. And basically, the trial was designed as a multi-center perspective, randomized double-blind clinical trial of clindamycin versus Bactrim for treatment of uncomplicated skin infections. Patients were recruited at 4 locations in Chicago, San Francisco, UCLA in California, and Vanderbilt, all medical facilities at the locations. Basically, to be considered a candidate for the trial, patients were eligible if they had 2 of the following signs or symptoms for 24 or more hours, and that was erythema, swelling, or local warmth, or a drainage of an abscess, a tenderness, a pain, and things of that nature. Also, patients were categorized as having cellulitis with inflammation and abscesses, or both, or lesions. Patients were excluded from the trial if they had superficial skin infections like impetigo, skin infections of the body that required specialized management, like in the genital or the hand areas, bites, infections, fevers that cause the infections, failure to having more morbid obesity, basically not being able to lose a certain amount of weight in a certain amount of time. And patients were also ineligible if they lived in a long-term facility, had cancer or oral inflammatory disorder that required treatment in the previous 12 months, or had a major surgery in the past 12 months. The subjects were basically men and women from the ages between 18 and 80, and they also did some children. The primary efficacy endpoint was the percent change in clindamycin from the baseline to the week 12 endpoint, or basically the ending of the endpoint. And then the secondary was the endpoint that was the percent of change from the Bactrim. The duration of the trial was from May 2009 to August 2011. The population was males and females, and adult males and females. The arms, patients were stratified into one of the 2 following groups on the basis of the characteristic of their infection before randomization. A group that included patients with larger abscesses or cellulitis, or a group that included patients with smaller abscesses. The protocol and the data analysis plan pre-specified that the limited abscess group and the larger abscess cellulitis group be analyzed separately because their treatment assignments differed in that they limited abscess stratum included a placebo group. Patients who had a single abscess with a greater diameter than 5 centimeters were stratified into a limited abscess group. All patients, including those with abscess greater than 5 centimeters in diameter, patients who had 2 or more sites of skin infection, and patients with cellulitis without abscess. The size of the abscess cavity was measured manually in 3 dimensions by width, length, and depth, and recorded. Okay, the statistical analysis. There is a lack of clinical cure. A lack of clinical cure was defined as a lack of resolution of signs and symptoms of infection, occurrence of side effects with necessary discontinuation of the treatment with the study of medication within the first 48 hours, or any one of the following test of cure visits. Occurrence of skin infections at a new body site, unplanned surgically treatment of the treatment infection, or hospitalization related in the infection. The primary null hypothesis was the clindamycin and Bactrim would have equal rates of cure. The study was designed as a trial with 80% power to detect the rates and the population that could be evaluated as the alpha level and beta level, assuming that we calculated between 524 patients, 262 for Bactrim, 262 for Clindamycin. There's several tests done, analysis, and data that was retrieved. Findings from trial are described in accordance basically with the Fisher exact test and the Chi-chart test and things of that nature. Abscesses were present in 160 patients, cellulitis in 280 patients, and mixed abscess and cellulitis in 82 patients. There was no significant difference between the groups that regarded clinical presentations, signs, and symptoms. Incision drainage was performed in 50% of the patients. Cultures were obtained in 296 of the patients. The most common baseline isolate found in a culture was the Streptococcus aureus, or Staphylococcus aureus. The rate of cure is the intention to treat the population at the test cure site was 80% in Clindamycin group and 77% in the Bactrim group. The difference was only 2.6%. In the population that could be evaluated, the rate of cure was 89% in Clindamycin and 88% in Bactrim. So as you can see, there's not that much of a difference between the both of them. Adverse events. Overall rates of adverse events were similar in Clindamycin and Bactrim groups. The most common adverse events in Clindamycin and Bactrim groups were diarrhea, nausea, vomiting, and itching. There were no cases of C. diff associated with diarrhea. Most adverse events were mild or moderate and resolved without treatment. There were no treatment-associated serious adverse events. Basically, there is no significance between the efficacy of Clindamycin and Bactrim for the treatment of uncomplicated skin infections in children and adults with major coexisting conditions. At the end of the trial, first we excluded patients with serious coexisting conditions and outcomes of skin infections. So basically, at the end of the trial, it was just determined that both drugs treat the conditions more or less in the same, more or less they treat the conditions equally the same. And if there's any questions, I can be emailed or reached at markalex44@hotmail.com, markalex44@hotmail.com. Thank you for your time.